The first is Dr. Chigozie. The first is Dr. Chigozie Wandu. Dr. Chigozie Wandu is a fellow of the West African College of Surgeons. She worked as a consultant anesthesiologist for more than 3 years at Rivers State University Teaching Hospital, formerly known as Braithwaite Memorial Specialist Hospital, Port Harcourt. In 2019, she joined the Department of Anesthesiology, University of Port Harcourt Teaching Hospital. She's a facilitator for the Safe Obstetrics and Safe Pediatric courses. She's also a member of the accreditation team for the West African College of Surgeons. Dr. Wandu is enthusiastic, vibrant, and hardworking. She's an active member of the NSA and participates in her conferences and other activities. Today, Dr. Chigozie Wandu will be talking to us on neuromuscular blockade and monitoring under anesthesia. Thank you very much. Dr. Chigozie Wandu, please, can you upload your slides and start your presentation? You have 40 minutes. Thank you. We ask that everyone keeps their microphones muted, please. If you have a question or comment, you can type it in the Q&A or in the chat box. Thank you very much. Or raise your hand.
We can't hear the voice.
Dr. Wandu, you need to unmute yourself, please. Dr. Wandu, please unmute yourself.
Paralyzing and awake patients. We should make sure that any patient that we are going to give neuromuscular blocking agent must be fully under general anesthesia. Because if this does not happen, the patient may have trauma. It's a very bad experience for a patient to be awake and be paralyzed. So this is a brief anatomy of the neuromuscular junction. The neuromuscular junction consists of a motor neuron, a motor end plate, and the synaptic cleft. This is actually where the transmission happens. The acetylcholine is the neurotransmitter at this point. So when a nerve impulse comes to the neuromuscular junction, it causes the vesicles, and it causes calcium to activate the vesicles, which will now release acetylcholine. And these are the junctional hooks and the acetylcholine receptors. So there will be binding of the acetylcholine to the acetylcholine receptors. This will cause more release of acetylcholine. So these are the steps. So when a nerve impulse comes in, acetylcholine is released and it goes to the acetylcholine receptors at the post-junctional membrane to attach. When this happens, more channels are open. Calcium goes in, sodium goes in, and potassium goes out. When it reaches a certain threshold, a muscle action potential is generated. That means that the junction becomes depolarized. Acetylcholine is rapidly hydrolyzed by the enzyme acetylcholine esterase, and the cycle continues. So, classification of neuromuscular blockers. We have two main types of neuromuscular blockers. We have the depolarizing and the non-depolarizing. The depolarizing, we have the short-acting, which most of we all know, succinylcholine, choline. Then under the non-depolarizing, we have the short-acting one, the gantocholine, which is the new agent, vivacurin. We have the intermediate acting one, atracurin, cisatracurin, becronin, rotorin, and we have the long-acting one. So still on classification, these drugs can be classified based on the agent, or based on the chemistry. We have the benzene lysine group, and we have the steroidal group. And we all have the new drug, the fluorofumarate group. During intubation. So this is simply two molecules of acetylcholine bound together through the acetyl group. And what this does is actually an agonist for the acetylcholine. So it stimulates the effects of acetylcholine. That is, it works like acetylcholine. And it blocks the neurotransmission because the junction is already depolarized. So it cannot be depolarized again. It works like acetylcholine. The only difference is that it's not hydrolyzed by the acetylcholine esterase. It's actually hydrolyzed by pseudocholinesterase or plasma esterase. And it causes its action by having a biphasic action. An initial contraction is seen before we now have a realization. That initial contraction, which we call fasciculation. Still, the onset of action of succinylcholine is rapid. So it's used for rapid sequence induction. Choline comes in as the ideal drug, and the duration of action is less than 10 minutes. So it's used to facilitate rapid tracheal induction. Sometimes, though that the duration is less than 10 minutes, there are situations where you may have prolonged action, when you have hypothermia, when you have reduced cholinesterase activity, or when you have the atypical pseudocholinesterase. You may have the reduced pseudocholinesterase activity in pregnancy, in liver problem, and so on. Let's talk about the complication of sozamectin. May have fasciculation, malaria, bradycardia, raised intragastric pressure. You may also have malignant hyperthermia, which is very rare. So I'm going to talk on hyperkalemia. You see hyperkalemia mostly when you have severe trauma, burns, and this peaks around 7 to 10 days. The reason for this is because of you have extra junctional acetylcholine receptors that are coming up. Those ones will now cause widespread depolarization, and there will be more extensive potassium release. Normally, in healthy people, acetylcholine and sozamectin causes release of potassium about 0.5 milli equivalent per liter, which does not cause any harm in a healthy person. But when you have people with burns, extensive burns, people with severe neuromuscular injuries, you may have the upregulation of the extrajunctional acetylcholine receptors, and these are what cause the exaggerated and extensive potassium release. Also, another effect we may see with succinylcholine is what we call phase 2 block. This occurs when you give an overdose of succinylcholine, and this causes the junction to be depolarized. The receptor continues to be open and ion flux continues. So you cannot the acetylcholine cannot come up to cause muscle contraction. So the paralysis continues. So there is continuous influx of sodium and calcium and continuous efflux of potassium. So the paralysis continues. In this one, the phase 2 block makes the paralysis to now look like that of the neuromuscular blockage. So you may have phase 2 block when you have when you have given an overdose of choline, or when there are issues that make the hydrolysis of choline not to take place. So I'm going to, this table shows us the difference between phase 1 and phase 2 block. Phase 1 block is the normal one we expect to have in choline. So when you use neuromuscular monitor to stimulate the patient, you will not have faith in phase 1 block.
Kovani Technologies, we cannot hear you. Kovani, please. Okay, so I think we lost the host there. He's playing the presentation. I guess he'll be back soon. Let's be patient. Thank you. Good evening once more, everyone. The host will be joining us shortly. He's having a bit of network issues. Thank you.
Hello, good evening, everybody. Hello, good evening.
Good evening, ma'am.
Like
Okay.
the features you will see when you use the neuromuscular monitor.
Okay, the presentation is back.
Non-depolarizer. So phase 2 block comes in when you have given an excessive dose of choline. So I'm going to be discussing non-depolarizing neuromuscular blocking agents. These drugs are competitive antagonists for the acetylcholine receptors. So these drugs, unlike the choline, unlike the depolarizers, they are not agonists. They bind to the receptors, preventing acetylcholine to bind there. So this is a table showing the different types of non-depolarizing neuromuscular blockage, their onset of action, the duration, and how they are metabolized. To be discussing atracurine. Atracurine is an intermediate acting muscle relaxant. its metabolism is independent of the liver and kidney. So it's good, it's useful when we have a patient with liver problem or kidney problem. So it's metabolized by ester hydrolysis and Hoffman elimination. Ladonosine is actually a byproduct and is implicated in, can cause some excitation in the central nervous system if you use a large dose, leading to seizures. So atraquinone comes in, is very helpful when we have patients that have liver problem, kidney problem. So we don't want to have prolonged duration of blockade. So we can use atraquinone. Well, part of the side effects might cause hypotension and it causes histamine release. You may also have bronchospasm from the histamine release. To avoid this, you can give the atraquinone by slow injection, or you can pre-treat with H1 histamine antagonist before you give atraquinone. Cisazacrone is actually an stereoisomer of atraquinone. It's about 4 times more potent, still an intermediate acting. It's still metabolized the same way as atraquinone. The only about it is that ladonosine is not too excessive here, so it does not cause any CNS excitation. So mivacurium is a non-depolarizing agent with a very short duration of action, and it's metabolized by the same way succinylcholine is metabolized by pseudocholinesterase.
Kovani, you are muted.
Potential in the blood and causing histamine release. So let's talk about pancreonine. The good old pancreonine, most of us very conversant with pancreonine. It's long-acting and onset of action is about 3 minutes. It's metabolized by the liver and primarily eliminated by the kidney. So you might have prolonged action when you renal or hepatic failure. Also causes an increased heart rate, blood pressure. So care is taken when you have patients, hypertensive patients. So it also causes an indirect, this increase in heart rate can be due to the vagolytic effect at the postganglionic nerve terminal, or can be due to its indirect sympathomimetic effect. Also, it causes an increase in catecholamine release. So mivacurium is an intermediate acting amino steroid. It's very cardiostable. So the only side effect about mivacurium is that it may cause prolonged blood up to date in the ICU, especially when given to females or those that have been on steroid use, or when you have septic patients. Rocuronium is an amino steroid, and it also has intermediate duration of action. It's actually not metabolized in the body. It's eliminated on chain by the liver and kidneys. So it's a good drug to use when you it's also when you increase the dose to 0.9 to 1.2 milligram per kg, it can give you a rapid onset of action that can almost compete with succinylcholine. The only thing is that the duration of blockage may be longer. So it can be used for modified rapid sequence induction. It has its own special reversal agent, that is sugar madness, and this is actually can be used to reverse even as soon as you give it. That's the beauty of sugar madness. So this is a table showing us the neuromuscular blockade agents and the way they are excreted in the body. The ones that are excreted unchanged and the ones that are excreted already when they are partly metabolized or redistributed. This is another table showing us the adverse effects of neuromuscular blocking drugs. So you can You can see the ones that causes sympathetic stimulation. You have pancreatin there. You can see also the one with vagolytic effect, pancreatin again. These amine release. You can see the ones that are implicated and ganglionic blockage. So I want to, this is just a table to show indications for the use of neuromuscular blocking agent in the ICU, in addition to sedative and analgesic drugs. Remember, I already reminded us that we must make sure that the patient we are giving neuromuscular blocking agent must have adequate sedation and must have adequate analgesia, because neuromuscular blocking agent does not offer those properties. So you can, the indication for using neuromuscular blocking agent in the ICU to facilitate mechanical ventilation, to aid in the trachea integration, and even to help the patient to tolerate the different modes of mechanical ventilation. There are some situations like tetanus, status epilepticus, you may have to give the patient neuromuscular blocking agents. This is another table showing us the complication of muscle paralysis. We have the short-term use, when we are used for a short term, the complication you may see. We have the long-term use, the complication we also see. So we are going to talk about the neuromuscular monitoring. Why do we have to do neuromuscular monitoring? We want to do neuromuscular monitoring to be able to evaluate the onset of neuromuscular blockage. One, when we want to intubate, we want to know that the patient is adequately paralyzed before we do our laryngoscopy. We also want to determine the level of muscle paralysis during surgery, especially for surgeries that you want to have deep paralysis, profound paralysis. Surgeries like retinal surgery, you may want to check the neuromuscular, assess the level of the neuromuscular blockage. We want to also evaluate patient recovery to reduce the risk of residual paralysis. Before we give reverse agent, we want to know that the patient has recovered from the paralysis. So we want that. These are the objectives. Why we want to do that? So remember that even the intermediate agent may give us residual polarization. That's why that sometimes when you may have experiences when you give reversal agent and the patient will intubate, after a while the patient will not have difficulty taking over or will be struggling to breathe. There may have been residual polarization because most of us use the visual or tactile evaluation to assess recovery of neuromuscular block, and this is very unreliable because even in the hands of experienced anesthetists, they might not be able to detect when you have 10 or 4 ratio less than 5 or less than 6 from looking at the residual reservoir bag or from doing some clinical tests like tongue protrusion, head lift for 5 seconds. Those ones are not very reliable. A reliable way to assess recovery from neuromuscular blockage is by the use of neuromuscular monitor. And we are going to look at some of the twitches, some of the tests that can be done and when they are not important. So single twitch stimulation, this is done at the onset of neuromuscular blockage. What happens here is a supramaximal stimulus is applied at a peripheral nerve for about 0.2 milliseconds at a regular interval, and the evoked response no set. A supramaximal stimulus is actually stimulus that is about 25% above the maximal stimulus that should stimulate a muscle fiber that should what will I say? That should activate muscle fibers. So when you give extra 25%, that is a supramaximal stimulus. So if there's a depression at for about 75%, then you expect to, if there is a depression of about 75% when you do the single twist stimulation, then the paralysis is ideal for abdominal surgery. So when you are doing abdominal single twist, you have to check this before you give the muscle paralysis, neuromuscular agent, blocking agent. Then after you do it, you now check it again. That's when you now see if the depression of the response is about 75%, then you can say that the neuro blockage has started, and we're ideal for abdominal surgery. We also have train of force stimulation. This one is using the supraparietal 2 heads. That's you give force stimulation. This is repeated every 10 seconds. So the observer compares the first twitch to the control, and then the fourth twitch to the first twitch. The ratio of the fourth twitch to the first twitch is actually what we call the train of 4 ratio. And you expect to have a reduction in the fourth twitch, which is affected first, then the third one, then the second, and finally the first one. If a non-depolarizing agent is used, this is actually what we call the fade. That gradual from the fourth twitch
Kovani Technologies, please can you unmute yourself and make your background less noisy? Thank you. Kovani, please. Good evening, everyone. The host will be joining us shortly. It's a pre-recorded presentation, so he has to play it. Thank you.
give your reverse agent, before you give your news to me, ideally you should check that the train of 4 ratio should be more than 0. Train of 4 monitoring actually is not useful in neutralizing neuromuscular blocking because all the 4 stages will decrease equally. There will not be that gradual there will be no fade, that the decrease will not be, will I say, sequential, or will not decrease gradually. They will all be equal, though they will be decreased. So in neuromuscular, in non-depolarizing neuromuscular agents, you will notice fade. You only notice fade when you use depolarizing agent if the block is phase 2. So you have the tetanic stimulation. This is giving a high frequency with a supramaximal stimulus. That's frequency from 50 Hz to 200 Hz. The only limit when the patient is awake and is sensitive, and it can elicit minor degree of blockage, which is very useful in the post-operative period. Only occur in the non-depolarizing block. We have the post-tetanic count. Well, this is actually useful when you want a profound neuromuscular block, that is like during retinal surgery, and it's mostly done after the tetanic stimulation. After the technique stimulation, and you give another stimulate, and you now have a count. In depolarizing, you will not see any count. So this is post-technique facilitation, which is seen in non-depolarizing, and it shows when you have that, it shows that the block is very intense. You now have the double burst stimulation. The double burst stimulation involves giving 2 bursts of technique technique stimulation at about 50 Hz for a current for about 0.2 milliseconds. It detects even the small degrees of blood than 10 or 4. And it also shows fade. So after, when you do this stimulation, how do you measure the response? Ideally, to be very objective, you measure the muscle responses. You can not just use your visual, you cannot visually assess the response. Ideally, measure it using mechanomyelography. Mechanomyelography will help us to measure the evoked muscle tension. Most times, the nerve we stimulate during the neuromuscular monitoring is usually nerve that is easy to access. So most time we use the ulnar nerve at the wrist, and we use to assess the adductor pollicis movements, that's which will steal from the flexion of the thumb. So this is the gold standard, this mechanomyelography that measures the evoked muscle tension. Is the gold standard, but it's still bulky and impractical for theater use. We have the electromyelography. This one measures a compound action potential that occurs during muscular contraction. We have acceleromyelography that can be used in the theater. This is similar to the mechanomyelography, but the acceleration of the contracting muscle is measured instead of the force of the contraction. So the onset, it's good for us to central muscles with rich blood supply. That is the diaphragm and larynx. And these are the muscles we want to paralyze during anesthesia, during intubation. Our target most often is to paralyze the larynx so that we can be able to intubate without stimulating the patient. And we also want to paralyze, and when we paralyze the diaphragm, that's why we take over the respiration. So we have to understand that the onset, the neuromuscular agent acts very fast on these muscles, and they will also faster from these muscles. Meanwhile, the peripheral muscles with relatively poor blood supply have slower onset of action, and recovery time also takes a longer time. So the importance of this is that during induction of anesthesia, we can use the neuromuscular monitor to assess the orbicularis oculi, because this orbicularis oculi actually is said to behave like these central muscles, like the larynx and the diaphragm, so it will actually By the time there will be disappearance of the hot twitch, then we can say it's the ideal time to intubate, because if we start waiting for the abductor policies to sit, by that time the larynx would have recovered from paralysis. So if we are going to use a single twitch to assess if we should be able to intubate, we have to do it with the orbicularis oculi, because that's the one that will have a faster onset and also a faster offset. Then during maintenance of anesthesia, we can use the post-technique count and the train of 4. They are very useful. And we also use the orbicularis oculi. During reversal, we can now use the abductor policies, because what it means that by the time we start having train of 4 more than 3, by the time we have like 3 twitches showing in train of 4, that means that the larynx and diaphragm has even recovered better, because they recover faster. So by the time this will be seen on the abductor policies, that means that the larynx, the likely thing, the larynx and the diaphragm are far ahead. So this condition where neuromuscular monitoring is recommended, neuromuscular monitoring ideally should be done for every time we use neuromuscular agents. But however, there are situations where it is very, very important that it is done. When you have given prolonged infusion of neuromuscular blocking drugs, or when you have used long-acting agent, or during long surgery, if you have done a surgery for 5, 6, or more than 8 hours, you want to be sure that you don't have recolorization. Or when you have patients with liver or renal dysfunction, you also want to be sure the drug has been adequately eliminated before you give your reversal agent. Also, when inadequate reversal may have devastating effects, like when you have severe respiratory depression or patient with morbid obesity, these people will definitely benefit from neuromuscular monitoring. So this is a diagram showing you what happens with it. You can actually see what's it called? You can see the amplitude, how it's decreased, what we call fade, the way it's going. This is what happens. Single twitch when there's nothing. By the time it starts, this is it. Then for succinct, this is control. What you have is they will be decreased in the response when they were all equal. All of them are equal. Then this also will show you non-depolarizing. So let's talk about active cholinesterase. These are agents that act indirectly. These are agents that act indirectly to increase the level of acetylcholine by binding to its metabolic enzyme, cholinesterase. So what this does is, at the time it binds to cholinesterase, so the acetylcholine will increase. And when it increases, it will now be able to replace the non-depolarizing agent from the receptor side and redepolarize the receptor. So what the reversal homeostasis does, it binds to the enzyme and increases which will now invariably increase the level of acetylcholine. Also, the half-life anticholinesterase is usually short. So if a large quantity of non-depolarizer is to be replaced, we may have to decrease the dose, or we may have to repeat to avoid repolarization, because this is all if it's given when the residual neuromuscular blockage is not adequate, we may have repolarization. Then also should remember that acetylcholine, neostigmine does not reverse the effect of succinylcholine. Rather, it potentiates it. Because what it does is that if you give neostigmine when the patient has received succinylcholine, it will now make what's it called, acetylcholine in this acetylcholinesterase that will not even destroy their choline. So it will make it to be more there and causing more. It will potentiate. It may cause a phase 2 block. So I want to briefly talk about sugar mothers. This is a new reverser agent, mostly used to reverse the steroidal agents. It doesn't have any effect against the benzene like phenol. And it's very effective. It doesn't need any co-administration with anticholinergic. Even at a dose of 4 to 8 milligrams per kg, it can. Using sugar mothers, you don't have to have residual, you don't have to have some recovery from neuromuscular blockage if you give sugar mothers. If you need to reverse, you can give no growing these minutes. In next 2 minutes, you are giving sugar mothers, and the patient will recover adequately. It has a high safety profile in patient with end-stage renal. This is so the drug is actually in high demand. So in conclusion, muscle relaxants are frequently needed during the administration of general anesthesia and mechanical ventilation of patients. We should remember that residual neuromuscular block may interfere with pulmonary mechanisms, impair the ventilatory response to hypoxia, impair pharyngeal function, and may lead to an increased risk of tracheal aspiration and airway obstruction. So we have to be sure, know the drugs and know when to give, and also know when to reverse and know the precautions to take. We need to have neuromuscular, we need to monitor the neuromuscular blockage by not just giving reverse agents to avoid repolarization. Thank you very much for listening.
Thank you very much, Dr. Chigozie Uwandu, for your presentation. Dr. Chigozie has spoken to us about neuromuscular blockade and monitoring under anesthesia. She introduced the neuromuscular junction, spoke about succinylmethonium, phase 1 and phase 2 blocks. She spoke about non-depolarizing neuromuscular blocks and blocking drugs and indications for muscle relaxation. She mentioned monitoring. She spoke about monitoring of neuromuscular blockade. She mentioned shigamatics, So thank you very much, Dr. Chigozie Uwandu. If you have questions for Dr. Uwandu, please write them in the chat box or in the Q&A. We'll go on now to our next presenter, who is Dr. Blessing Akata, MBBS DA, postgraduate diploma in general intensive care from Israel. She's a fellow of the West African College of Surgeons. She's a consultant anesthetist and currently the head of department at Department of Anesthesia, Lagos State University Teaching Hospital. Dr. Blessing Akata will be talking to us on brain death, diagnosis, and confirmation. Thank you very much. You have 40 minutes.
Everyone, I welcome everyone to today's edition of NSA webinar series. The topic before us today is brain death. Diagnosis and confirmation. Before we go into more details, I want us to take a critical look at this clinical setting. I'll be using this introduction to discuss the topic. One of the most fundamental questions that a doctor may be asked to answer is whether or not the patient is dead or alive. One would think that any issue or controversy regarding the determination of death will feature prominently in medical curriculum, and debates about death are relegated to the narrow specialty in medicine, to the extent that most practicing physicians today are remarkably unaware about the state of knowledge on this question. The diagnosis of death, confirmation and certification are core skills for doctors in the UK. In other parts of the world, and I think almost everywhere, the diagnosis and declaration of death remains the legal responsibility of the medical practitioner. The diagnosis of death, it marks a point in time for which there are consequences, like stopping life-sustaining intervention, opportunity for organ donation, executing the decedent's will, sharing of the estate and property and land transfer, and all the other things that usually follow death. Death, let's look at some definitions. Death is a biological event. It's a permanent cessation of critical functions of the body, of the brain. Master coordinator of all the functions of the human body. And is dead. It's like all you have remaining is a collection of cells that will soon go into dissolution. Consciousness. Consciousness is a state of being aware and being awake and aware of yourself and your environment. The vegetative state, the patient will be arousable, but the patient will not be conscious. Such a patient is not said, cannot be said to be diseased. Coma is a state where you have no awareness and no arousal, cannot be woken up, cannot be aroused. Brain death. This is an irreversible loss of all functions of the brain, including the brainstem. The essential findings of brain death is coma, loss of brainstem reflexes, and apnea. This is the diagram for the brainstem. See the cranial nerves that are taking their origin from there, and this is just to show you the arrangement of the cranial nerves at the brainstem. So, the neurological criteria. So the criteria that is employed to diagnose brain death on the circumstances in which the physician is called to come and diagnose death. For the somatic criteria, those are the criteria, that's what you observe when you see the physical corpse. For example, if you see that the head has been cut off, the decapitation, that one, you don't need any test to say that the person is dead. If you can observe rigor mortis and all that, you don't need any test to say that such a patient is such a body is dead. The other criteria is circulatory death. Here, there is cessation of heartbeat. The somatic death, that one is applicable in the somatic criteria is applicable in the community, because even lay people, they can know when somebody is dead. When you see that the head has been cut off, you know that such a person is already dead. You don't need to be a doctor in order to be able to know all those things. Then for the circulatory criteria, there must have to be cessation of heartbeat. This is common in hospitals, other areas of the hospital, in the emergency room, other areas of the hospital. So you'll be looking for a security criteria to diagnose death. In the critical care unit, where patients are undergoing all forms of organ support and all that, you need neurological criteria to be able to diagnose that the patient is dead. So these criteria that are used for diagnosing brain death, they differ from different parts of the world. For example, in the UK, if a patient is brain dead, even if, of course, they be supporting with supporting organ ventilation and all this other, it means that the patient is dead. In America, once the heart stops beating, that one is equivalent to death. In Canada and Australia, died. Okay, I've already mentioned that these are somatic criteria for diagnosis. Okay, I've already talked about this also. So the circulating criteria. So that you have an isoelectric electroencephalogram, and before you know it, the patient will become apneic. So you have a circulatory arrest. At the same time, there will be circulatory, the circulation, yes, there will be circulatory arrest. That will cause a structural damage to the brain. Then, at the same time, patients have to stop beating. Patients will be unconscious and also apneic. So, the essential components for this circulatory criteria is that there will be no further resuscitation attempt for the patient. Once you are using circulatory criteria to diagnose death, and you have to observe the patient for a minimum period. This period of observation varies. Some people say 60, some 65 minutes, others are saying 100 and something minutes and all that. Then you have to prohibit all activities that might restore the cerebral circulation. Once you have diagnosed that the patient's heart has stopped beating, you no longer need to continue doing all the resuscitation to bring back the heartbeat, to maintain blood pressure, nothing. So, diagnosis of brain death by neurological criteria. Here, you confirm that patient should have been in profound coma, and it might be maintained on mechanical ventilation. And these patients are usually found in the ICU, like I've already said. So here, the essential component of this criteria is that you must establish the etiology of the patient, the cause of the injury or insult to the patient. It must be clearly established. When you are not sure the diagnosis, you have not done any investigation and all that, you cannot just assume that the patient is brain dead. The etiology must be established. Then you exclude all the reversible causes of coma. Then you do a clinical examination for coma, that is profound coma, abscess of brain stem reflexes, and apneic test. In order to establish the etiology of the brain death, you will take history. There should be either there could be a history of trauma, aneurysmic brain injury, either the patient had a cardiac arrest and recovered, or you have a metabolic brain injury. There must be clearly established diagnosis of the disorder that led to death. Underlying neurological diagnosis must be apparent and well documented. So whatever the diagnosis is, it must be sure. and thoroughly documented. Also, this patient's condition will have progressed over time so that you could say, yes, it's now, patient has now evolved from severe brain injury to brain death. You need to delay the evaluation of a patient for brain death for at least 24 hours after there was either there's cardiopulmonary arrest or something. You have to delay the examination for at least 24 hours because there are some conditions that if you do not wait for long, like if there is a hypoxic brain injury or in cases of hypothermia, if you didn't wait enough before you start doing all the evaluation for brain death, it could be that the patient will actually recover. So don't jump into don't be in a hurry to go and evaluate the patient for brain death. You must have to wait for 24 hours. Appalling conditions. All these ones will have to be excluded before you can begin to think that the patient has a brain death. Even electrolyte abnormality like hyponatremia is the commonest abnormality that you find in brain death patients. You have to check the blood glucose, the phosphate, magnesium, all these things have to be within normal range. Endocrine abnormality, hypothyroidism, hypopituitary, these are all things that can cause reversible coma. Before you make a diagnosis, must make sure that you rule out all the things that will depress the central nervous system. There should be no sedative or intoxicating compound, chemicals, or drugs. Patients have been operated for the patient to recover from the effect of those drugs. The patients have had large doses of drugs, those little consultation. And if lipid soluble drugs can be used for the patients, all those two have to be put to consideration because
Good evening, all. I think we lost the host again. I'm sure he's trying to join network issues. Thank you very much. Kavani, please unmute yourself. Thank you. Kavani, please unmute yourself. We cannot hear. Thank you. Kovani, we cannot hear you, please. We cannot hear the presentation. Kovani, are you having audio issues? Do you want Dr. Akata to speak over the presentation?
Okay. Ma, please, what did you say?
Are you having audio issues? We cannot hear you. Do you want Dr. Akata to speak as you upload the slides?
Okay, please should. She can do that.
Dr. Akata, please, do you have your presentation? Can you share your slides from where he stopped?
Okay, let me do that.
Thank you very much, ma'am.
Can you see it?
Yes, please. Can you put it on full screen on slideshow mode?
Where were we safe? I think we were. Okay. Slideshow mode. Okay. Okay, can I continue from here?
Yes, please. Thank you very much.
Okay. Okay, as I've said, this hyponatremia is one of the commonest abnormality found in brain dead patients. So other metabolic things like glucose, phosphate, magnesium, they should all be within normal range. And you have to exclude endocrine abnormalities like hypothyroidism, panhypopituitarism, and adrenal dysfunction. So cerebral depressants like sedating or intoxicating compounds, chemicals or drugs should be excluded. You have to take into consideration how long the patient has been sedated, the doses that were received, and the agents that were used. Like if you use a lipid-soluble agent like taupental, you have to know that the elimination half-life is 5 times. Also note the duration of the infusion. Then there could be altered pharmacokinetics in the course of treatment, high doses, and also active metabolites. Sometimes you might need to give antidotes such as naloxone or flumazenil for opioids or benzodiazepine. there should be absence of neuromuscular blocking agents. If patient had a muscle relaxant in the course of treatment, make sure that the patient is adequately reversed, and you have to confirm it with a nerve stimulator. Then you need to check the plasma concentrations of some drugs. For example, alcohol level of the patient, because some deeply comatose patients have been found to be intoxicated with alcohol. So before you carry out the neurological examination on a patient, these conditions must be fulfilled. The patient must have been persistently been in a profound coma with a GCS of 3. There would have been an examination that showed the pupils have been fixed and dilated. There will be no cranial nerve reflexes for 4 hours, and the vital signs too should also be stable. So what should these vital signs look like? The blood pressure, the target should be over a 90 millimeters. Some people say over 100 millimeters of mercury, but the mean arterial pressure should be over 60 millimeters of mercury. If the patient become severely hypotensive, then you cannot go ahead with the examination of brainstem. You must have to make sure that the patient's vitals are okay. You can use fluid or vasopressor to increase the blood pressure of the patient. Then oxygenation should be okay, adequate. You give a high FiO2, you should get an SpO2 of 90 to 100. Then the temperature, it should be over 35 centimeters, over 35 degrees Celsius. You have to exclude hypothermia as a cause of coma, like we commonly found in if the patient was undergoing any form of therapeutic hypothermia, or if the patient was a case of drowning. If hypothermia is implicated as a cause, you allow up to 24 hours for the temperature to return to normal before you can proceed with the evaluation. This is a diagram illustrating the cranial nerves, how they are originating from the brain stem. See the ones coming out from the midbrain, the pons, and the medulla. All these cranial nerve effects are going to be affected when there's a damage to the midbrain, and those are the nerves that we are going to be testing. So these are the cranial nerves, nerve 4 and nerve 5 and 7 is testing for reaction to supraorbital pressure. Also, same 5 and 7 is the corneal reflex. Pupils should be fixed and unresponsive when you are testing for nerve 2 and 3. Then for nerve 3, 5, nerve 3, 4, 6, and 8 is nystagmus, that's vestibulo-ocular reflex. This is again the schematic diagram showing the various cranial nerves and the place where they are located in the brainstem. So now the diagnostic protocol. Assessment of the brain death in a patient should proceed with certain principles in mind. As I've already said, the cause of the coma must be established. You must ascertain that this cause is an irreversible cause. You should exclude all the major co-founding variables, which I've already mentioned, and you now carry out all the tests for the brain stem reflexes that are possible to perform. So for the assessment of coma, you start with a verbal stimulation. Start with verbal stimulation. If there's no response, you proceed to moderate stimulation. You can use patellar in between the toe and twist, or you can use you can apply supraorbital pressure. In this, you observe for autonomic response. There could be increase in heart rate, there could be increase in blood pressure, and also withdrawal movement. The pitfall with this test is that there are some reflexes too that you can see. You can notice some movements. Those movements are just spinal reflexes. They are not. Doesn't mean that the patient is okay. So you have to watch out for those movements. So spinal cord reflexes, these are bodily movements that are secondary to, they are bodily movements that are secondary to spinal cord reflexes. They could be observed after the brain has died in patients. And the publication shows that about 39% of the people in some studies, they had all these movements. And this movement could persist until asystole occurs. This movement, like I said, they are just spinal cord activity. It doesn't mean that there is activity of the brainstem and the cerebrum. The movement that you can observe, they include spontaneous movement, respiration-like movement like shoulder elevation, abduction, back arcing, leg movement, head rotation, brief movement of the body to the sit-up position. In fact, you can be deceived to think that this patient is sitting up, can be dead. That's the Lazarus sign. Then you can have the triple response, that's the Babinski response, superficial abdominal reflexes. In all of this, there's no movement of the face. No, the facial muscles, they are all those muscles are innervated by the cranial nerves. So this is picture showing different postures that you can see. Whenever you see a decerebrate or a decodicate posture, that patient cannot be brain dead. It shows that the CNN is still intact. You cannot make a diagnosis of brain death when you see a decodicate or decerebrate posture. But the C, the triple response, that one is a spinal cord reflex that is compatible with brain death. So even if a patient is brain dead, when you do the Babinski response, you are going to get this response. So next thing we want to look at now is the pupil response to light. The normal response is a brisk constriction of the pupil. But for a brain dead patient, the pupil will be in one position. It's going to be dilated 4 to 6 centimeters, fixed. It could be oval, round, or irregular shape. The problem with this assessment is that for pre-existing, if you have a pre-existing pulmonary abnormality, that will affect the results. If there was previous surgery or there's trauma to the eye, or they are using medications like atropine or phenylephrine, that's going to affect the result that you get from this particular test. Next thing we want to look at is the corneal reflex, which is testing cranial nerve 5 and 7. The normal is blinking of the eye on both sides if you apply this cotton wool to the cornea. So from these two photos, you can see one person, the cotton wool is already touching the cornea and the patient is still looking, it's not blinking. This other person, the cotton wool has not yet touched. So the normal reflex, if the brain stem is intact, is for the patient to blink. But if there's no response, that means that there's brain death. From these two, we can only easily see which of them is not responding. The next is the oculocephalic reflex, which is the door eye reflex. Here, you hold the head in the mid position and you gently turn it to one side. So when this is done, the normal response is for the eye to turn to the opposite side of the head movement, as if it is lagging behind. That means if you turn the head to the right side, the eye will turn to the left. Or the difficulty with this assessment can arise in a situation where you have a significant orbital edema. When you have significant orbital edema, the examiner will not be able to open the eye properly to observe this movement. Then if there is significant conjunctival edema, then even if the examiner can open the eye, because of the conjunctival edema, the movement is not going to be appropriate. So you will not observe this response very well. Contraindication for this test is if you suspect or you know that the patient has cervical spine injury or unstable cervical spine. So next thing we want to do now is the oculovestibular reflex, also known as the caloric test. It tests for cranial nerve 3, 4, 6, and 8. Before this test, you need to get an otoscope to look into the ear and make sure that the tympanic membrane is intact and that there's no wax, because if you have wax in the ear, the test is not going to be sensitive. You will not pick. It won't be sensitive. You make sure that the patient's head is elevated at 30 degrees so that you have a maximum response. You need to align the circular canal so that the thing can respond very well. After that, you now instill into the patient's ear about 50 to 60 ml of ice cold water. Contraindication for this test is when you have a fracture of the base of the skull. The normal response for this test, if the brainstem is intact, is you have nystagmus movement. Here, the eye turns quickly away from the side where you put the cold water, and then it will now turn slowly towards the other side. So as if the eye is shaking. That's the kind of movement that is called nystagmus. So the lower brainstem nerves, the 9th and 10th nerve, you assess it with the pharyngeal, that's with the gag reflex. This is when a tongue blade is inserted into the back of the throat. You're supposed to observe palate elevation. Then the laryngeal or cough reflex. For this test, a suction catheter is introduced into the endotracheal tube or tracheostomy tube to deliberately stimulate the carina. The normal response is for the patient to cough, or at least you can notice some chest movement. If you didn't see response in all those things, it means that the brainstem is not functioning. So after you have done all the other tests, you've tested for coma, you have done the brainstem reflexes, and you did not see any response, then you can now proceed to do the apnea test. This apnea test is a very dangerous test because one of the complications of the test is that the patient can have a cardiac arrest in the course of the test and die. So you do not want a patient that you have not seen any other thing. You didn't want, it's only when you did not see response in another area, you should proceed to do this test. So this test, it cannot be carried out if you have high cervical spine injury or the patient has poor respiratory function, because one of the components of the test will be a time where you are going to test for spontaneous respiration. So the apneic test, what are the components? First, you have to discontinue the mechanical ventilator. So you discontinue the ventilator for a long enough period so that CO2 can accumulate to reach a critical point, causing acidemia, just trying to cause hypercarbia to stimulate respiration. Then make sure that during this time, the patient has adequate oxygen. Oxygen must be running in the circuit. You can even use a CPAP machine to make sure that there's adequate oxygen. This time you are monitoring the SpO2. Then there should, and arterial gases. There should be aspects of spontaneous respiration after a specific period of 5 to 10 minutes. So the procedure for the test, you presynate with 100% oxygen for as long as necessary. Make sure that SpO2 is normal. You check for ABG, the PaO2, PaCO2, they should be normal, and the pH, they should be normal. If this is not normal, you cannot proceed with the test. You must make sure that these vitals are normal. Then, after all those things, next is to disconnect the ventilator. Continue to, when the ventilator is disconnected, you continue to deliver oxygen to the patient. That you now inspect for spontaneous respiratory effort. You can look at, maybe connected to the reservoir bag can be connected to the patient, or you look for chest or abdominal movement. And after about 5 minutes, you check. You can repeat at 5 minutes interval. By the time you are checking the for spontaneous respiration, the PaCO2 should be over 8 kilopascal, and the pH should be at should be less than there should be acidemia. You should see a pH of less than 7.3. So you give allowance of about 10 minutes for change in PaCO2 to occur, because in patients, especially in patients that have a chronic respiratory disease, those of them might have been used to high level of carbon dioxide. So you need to give time so that they can accumulate enough carbon dioxide to be able to stimulate spontaneous respiration. Then the vital signs, if they are unstable, like if the patient is desaturated, you have to stop the procedure and start to give oxygen with CPAP or whatever means that is available. make sure that the patient is well oxygenated. Then if the patient is becoming hypotensive, you must also stop the test and make sure you give vasopressors, give fluid, and make sure that the vital signs are okay. Then you now do a visual inspection of the chest and abdomen. On the chest, you will typically see movements or even abdominal movements that are synchronous with heartbeats. It doesn't mean that it's respiration. Those are movements that are synchronous with a heartbeat. If despite hypercarbia and acidemia, there's no attempt at spontaneous respiration after for 5 to 10 minutes, this apneic test is positive, is diagnosis of a brain death. Confirmatory test for brain death. So brain death is a clinical diagnosis, but there are situations where the preconditions for the determination of brain death cannot be met. Like if all the conditions I've already mentioned before, if the patient cannot meet those conditions, or there are limitations to the test that can be done, like when there's whether there's the surgery to the eye or direct eye trauma and all those things that will make you not to be able to do this other brain test, then you will need a confirmatory test to be able to diagnose brain death. You cannot rely on clinical parameters alone. So these are the conditions that will require a confirmatory test. So if you have periorbital swelling, direct eye injury, otorrhea, all those that I've already mentioned, and patients do not fulfill the criteria. So the confirmatory tests that are available, they mainly test to confirm they are tests to confirm the clinical findings that we have already talked about, and they rely on the demonstration of the absence of parenchymal blood flow to the brain. Others, like the electroencephalogram, is relying on the fact that there will be no electrical activity of the brain. So the cerebral angiography. So the common techniques that are used to demonstrate complete cessation of cerebral circulation, they include 4 vessels cerebral angiography, CT angiography, MRU angiography, radionuclear imaging, and transcranial Doppler. So of all this one, the 4 vessel cerebral angiography that demonstrate the absence of intracranial blood flow is the gold standard test to confirm brain death. But the problem with it is that this is only available in specialist center. Other confirmatory tests like the EEG and the other one that I've mentioned, those ones are not reliable, so they are therefore not recommended. So now you have gone through everything, you've taken history, you carried out all the tests, and now you have found out that the patient is brain dead. What are the physician's responsibility? Right from the onset, you have to carry the patient along and explain everything to them to prepare their minds, let them know exactly the situation of things. Then you have to break the news to them in a nice way, and also now opportunity to ask the patient if they want to donate organs or whatever they want to do. That's your responsibility. So in summary, the diagnosis of brain death remains the exclusive responsibility of the medical practitioner, especially the critical care physician. Clinical and radiological evidence of an etiology are irreversibility of the patient's neurological condition, plus outside response to brainstem, plus outside response to pain, brainstem reflexes, and apnea are diagnostic of brain death. Increasing awareness among the masses about early diagnosis of brain death and the requirements for organ donation has mandated a need for diagnosis of brain death with utmost accuracy and urgency. My sources. Thank you. I'll take questions.
Thank you very much, Dr. Akata, for that presentation. Dr. Akata has just spoken to us on brain death diagnosis and confirmation. She defined brain death, and she told us different assessments of brain death that there are: somatic, circulatory, and neurological. She told us that the conditions some conditions have to be met before testing for brainstem reflexes, and showed us those conditions. And then she mentioned the confounding variables that have to be excluded. And then she described the tests for brainstem function and some confirmatory tests. And then she also mentioned the physician responsibility when it comes to brain death. So we thank the two presenters for their very good and lucid presentations. There are some questions in the chat box, so I'm going to take Q&A now. So I'll start reading out some questions. Thank you.
Recovery.
The first question goes to Dr. Wandu. The question is, what is the mechanism of female gender causing prolongation of vecuronium? And then another question is, please explain more on postoperative residual curarization. And then a third question, at what dose can Sugamadex be given for immediate reversal? And then the fourth question, what is the mechanism of action of Sugamadex? So I'll allow Dr. Wandu answer her first four questions. Please, the host, unmute Dr. Wandu. Thank you.
Good evening, all. Can you hear me?
Yes, please,
we can.
I hear you.
Okay. The question about the mechanism of action of prolonged duration of action of vecuronium in the female is actually because women seem to be more sensitive to muscle relaxants, even pancuronium and rocuronium. This can be attributed to the gender-related differences in fat and muscle distribution. Hello?
We can hear you.
Okay, so that can be the reason why we tend to have it more, because being a female is already a risk factor. Females seem to be more sensitive to the actions of neuromuscular blockage due to the fats and muscle distribution. Then the second question is, sorry, let me get the second question. The second question. Okay, postoperative residual curarization. Well, this happens when after general anesthesia, the patient, and after reversal, the patients tend to still have some weakness in breathing. So that means that probably the reversal agent has not adequately reversed the paralysis. And this happens when the patient is given the reversal agent when the train of 4 is less than 0.9. That's why it's advocated that neuromuscular monitoring is ideal when we use neuromuscular blockage, that we shouldn't base our assessment only on visual and clinical signs, that we should be more objective. When we use train of 4 more than 0.9, we are not likely to have postoperative recolorization. So this happens when after reversal, the patient also finds it difficult to take over the respiration. It's one of the common causes of admission in the PACO after surgery. The next question is, at what dose can sugar mothers be given for immediate reversal? Sugar mothers is actually given at a dose of 2 milligrams per kg, but it can also be given up to 4 milligrams per kg, or even up to 12 milligrams and 60 milligrams per kg, especially if you give rocuronium at the intubating dose of 1.2 milligrams per kg. You can increase the dose of sugar mothers up to 16 milligrams per kg. The ideal dose is 2 to 4 milligrams per kg body weight. Then the mechanism of action of sugar mothers. Sugar mothers is gamma cyclodextrin. It's a three-dimensional structure that has a hydrophobic, it's like a donut. You know how a donut has the ring inside? So it has that hydrophobic cavity, and the exterior is hydrophilic. So that cavity binds with the rocuronium. So it now binds tightly, covalent binding 1:1 ratio. What this does now, it keeps this complex form, these donuts and the rocuronium formed complex will now be in the extracellular fluid, making the neuromuscular agents making the neuromuscular blocker that is available at the receptors to be less. And when this happens, it will now cause more of, movement along the gradient. It will now make more of the neuromuscular blocking agent that's at the receptor to move out, because already the one in the plasma is already bound with the, with the sugar mothers. Thank you.
Thank you very much, Dr. Wandu. So I'll read out the questions for Dr. Akata. The first question is, for legal issues surrounding brain death, how will we manage a case of declaring brain death and there's recovery of activity? How can this be handled? I think I'll just read your questions one by one. Dr. Katama, please, can you unmute yourself?
Okay, can you hear me now?
Yes, please. Thank you.
Okay, that's how to avoid declaring brain death when the patient is still alive.
How would you manage a case of declaring brain death, as in a patient was declared brain death and there was recovery of activity? How can this be handled?
Okay. In fact, that has happened, especially for children. So that's why we need to follow all the processes that you need to follow before you can declare that the patient is brain dead. Because there have been stories of children who were declared brain dead and they were taking them to go and donate organs only for the children to recover. And this particular case that I mentioned, I put the reference in my sources. I think we should all go and read about it, about this patient who was declared brain dead by all the available. In fact, there's a lot of controversy going on now about this criteria for brain dead. But I just said, let me just stay out of the controversy. I just stay here. And you know that this particular topic is actually the purview of the neurologist. So I'm just in this area now, so I'm not really. So you follow all the processes to make sure that you are not in a haste to pronounce that the patient is brain dead. Then for the pediatric patient, they say that for a child that is less than 5 years old, you cannot say that such a patient, a child that for pediatrics, it cannot be brain dead. I can't see my screen. What have I touched?
It's okay, ma. You can just go on with the answers.
Okay, so what I'm saying is that in order to avoid that, make sure that you follow the protocol very well. Then there are some other things too that they do. They asked those questions, but let me just take them now because somebody asked what is the minimum number of physicians that is required to do the test and what should be the specialty. The minimum number of physicians that should perform this test independently is 2. But as for the specialty for those people, it varies. Some country will insist that there must be a neurologist, but like a country like us in Nigeria, how many of them do we have? You understand? Then there are some countries too that we, and what is constant is that those people that are testing for brain death, none of them should have any, none of them should be a member of the transplant team because they will obviously be biased towards their diagnosis. So there should be 2 physicians. Those 2 physicians, one of them should be the doctor that is responsible for taking care of the patient who has been examining this patient since. Then another doctor, not necessarily a neurologist, depending on which part of the world that you are looking at. So if 2 individuals are doing all these tests and they are confirming all this, then the chances of somebody making a mistake will not be there. And if we make sure we follow those criteria that we're to follow, and we make sure that we have excluded all those causes, we had a definitive diagnosis, we are taking a history, and we had investigations that show that this patient has a kind of brain injury that can result in irreversible loss. All those things, we have ruled them out. Then when we make the diagnosis, our chances of having that kind of embarrassing situation of declaring a patient brain death and the patient will recover again. Then somebody asked a question about what time should we wait for children. Honestly, for this presentation, I did not look at pediatrics, but what I know is that in children under the age of 5, you cannot declare them to be brain dead. And also, we should also note that children too, age is on their side, everything is working very well. Like the cases that I've seen that recovered. In fact, there was a video I watched. I think the child was like 11 years old or so. He was brain dead and they were taking for organs, something. All of a sudden, he woke up. So the child was 11 years. Was an 11 years old child. So this thing is common in children. So those are the things I can remember about children. Okay, somebody asked what are the devices that you can use to give oxygen during the brain death. In the brain death, the components are that you stop mechanical ventilation. So if you are using a ventilator of course, the ventilator, all you can just need to do, switch it to the simultaneous mode and leave it for increase the oxygen flow and all that. Switch it to the simultaneous mode so that the patient will not be, you now observe whether the patient is going to breathe spontaneously and make sure the oxygen is going in the system. You can use high flow nasal oxygen cannula. You can equally use a CPAP machine. But the important is that you should stop ventilator for that 5 to 10 minutes that you are watching out for respiratory effort. Okay, somebody said how we should withdraw the ventilative support in Nigeria. In Nigeria, honestly, I did not really know. I don't know in fact, many countries, it's only countries who have this transplant program. They are the ones who have a robust protocol where you can say, okay, if this one happens, this is how you should do about it in case they want to donate organs. Here in Nigeria now, we're not yet doing those type of transplants. We can just take a kidney from a living person and share and all that. We're not yet collecting a transplant from dead people yet. So I don't know what the protocol is in Nigeria right now. But I know my experience I had about 2-3 years ago. Of course, this is the responsibility of the physician. You have to carry the people along from the beginning and let them know that right now that continuing all these things is futile. So this ventilator will have to be discontinued. Once you have followed all the protocols, so many people have confirmed it. After all, the Bible said that the matter of 2 or 3 witnesses, a truth shall be established. So if you have many more people who are confirming it, you have to be able to talk to the patient, the relations and convince them that it is time to disconnect the ventilator. I think I've answered all the questions. Okay, I think I've answered all the questions I can see now. The prevention of brain death is legally accepted in Okay. Okay, so, okay, that's, somebody is asking if declaration of brain death is legally accepted in Nigeria. Honestly, I don't know the legal status of Nigeria. I didn't find that one out. I think I saw so many powerful people in the audience, so I'm sure that they will be able to help me out in that area. I think I'm done with the questions.
Okay, ma. We have Oluwakemi raising her hand, so I'm going to ask her to unmute herself.
Okay. Okay. Because I'm done for brain death in some other
Good evening, everyone. Dr. Akata, thank you so much for the robust presentation, and Dr. Wando. Please, my take on about the withdrawal of ventilation from a diagnosed brain dead patient. In Nigeria presently, we don't have the legal backing to take anybody off ventilator for now, because Nigerian law does not, so far, has not yet been able to recognize brainstem death as a component of death in Nigeria. So that ethical problem is still there for us as intensivists. That, okay, you've made a diagnosis, who is going to bail the cat and disconnect the patient from ventilator? Also, considering the fact that in this our environment, most people, it's difficult for them to accept, oh, you are still ventilating, heart is still beating, so how can it be dead? We are praying, pastor said patient will wake up. So that aspect is always there, that people will keep on believing that, no, don't worry, wake up, we are praying. But aside that, we don't have the legal backing yet in Nigeria to say, okay, the diagnosis has been made, now take off ventilator. So taking a patient whose heart is still beating off a ventilator in Nigeria is still taken as euthanasia. It's like it's like still taking an assisted death. So I think that the Critical Care Association, NSS Association, we have to, bring this to the awareness of our legislators, so that they can start incorporating this in our legislation, that, okay, brainstem death is a component of death and it is recognized worldwide. But for now, we don't have such legal backing to disconnect anybody from ventilator so far. So that ethical issue is still there, that is still yet to be addressed. Thank you.
Thank you very much. Thank you very much, Dr. Oluwakemi, for that submission. It's actually a very dicey one. And you're absolutely right. The NSC and Critical Care Society of Nigeria can look into it. We can work with the neurologists and neurosurgeons. Dr. Shinaika is raising up
Thank you.
his
Sorry,
hand.
I want to say something.
Okay, ma'am.
Thank you so much for that contribution. I think what usually happens is that once you have a brain death, in a short while, maybe our critical care is not so excellent to keep a patient alive for 20 years or even 5 years or something. After like a week or 5 days or something, for whatever, the thing everything will just stop. That's what happens. Thank you. I'm done.
Thank you very much, okay. Dr. Akata. Yeah, and I want to respond to the last comment. It's not exactly true that you can't take off a patient off the ventilator in Nigeria. Brain death is a clinical diagnosis. It's like you diagnose somebody to have malaria, and you start treating the person, and you say, oh, because it's not in our legal system, that you should treat malaria or cerebral malaria. When you make following what she has said, there's what we call international standards. Okay, most of our practices, even if you get involved in any legal issue, they are going to look at what is the international standard concerning that practice. Now, when it comes to brain death, true, there are no clear guidelines that has been developed to say that this is what you should do in Nigeria. But there are guidelines that guide, processes and standards that guide practice of medicine all over the world. So when you are managing a patient in the ICU, all the things she has said, if you follow all those things she has said, and you arrive at the diagnosis of a brain death, you follow the processes of discussing the relation, and letting them know the futility of care in, managing that patient. Now, there are several, options available. One, they can decide that, okay, for now, we want that patient's care to still continue, okay? They can say that we want the patient, you want it to just withdraw support and let's watch. They can say we want you to withdraw support. Now, the point is that if you carry the patient at the relations along from the beginning and you let them know what you are talking about, you're going to get, as we have gotten in our own center, many of them actually ending up agreeing with you, okay? But the truth is that you will not just suddenly go and just put up the ventilator, okay? You must discuss the primary caregiver, even your localities committee might be involved, the primary physician might be involved. It's not something that you can just do in a rush. You must get everybody along and discuss this issue until you are able to get that clearance. Okay. Now, even when it comes to some group of patients, you can even not take the consent of the relations to stop supporting the patient. You must seek consent of the ethics committee or seek consent of the court in some instances. Okay, so it's not totally true that we can't take up the ventilator, but once you follow the processes, it's something that can be done. Now, let me just add that it is important that in this part of the world, we have guidelines that we can follow that will say, okay, this is a guideline from Nigeria. And that guideline is going to take note of our shortcomings. Because what she has said, if you notice, there's few things that might be difficult to actually do or practice in Nigeria. So that's where local guidelines comes in. But as far as what operates internationally standards, if you're able to follow that sufficiently, then you can get to a point where the patient can be put off or can be taken off the ventilator. It's something that you can't do in a rush. You must be protected by what the book says, what the standard guideline says. That's what I would say. And because of this meeting, let me just add, because of this meeting, and because I know there is a lacuna in the care of patients when it comes to this level, I sent a Google form to us because we need to find out, even amongst us doctors, you discover that some of us are biased when it comes to this care of this patient at this point. So we are going to come together. I think NSA, critical care, and other societies, we need to come together to develop something. But that is not suggesting that we cannot manage brain death in Nigeria. Thank you.
Thank you very much, sir. Dr. Akata, there are two questions for you. We have to quickly take them because we want to quickly round up the meeting. The first one is, I think you spoke about that. Someone is asking, can you clarify the status of the physician that will make the diagnosis? Maybe you want to say something about that. And then the second one is, go on, ma, please. Thank you.
The status of the physician, it depends on which part of the world you are talking about it. Like I read one thing from India. India said it could be anybody, but there should be two people, and those two people, one should be the physician managing the patient primarily, then another physician, and both of them should not be part of the transplant team. Some other parts of the world, they will say that there must be people doing it, must be consultants, and there must be neurologists. Next question.
The next question is, someone is asking, please, for patients on ECMO machines, how do we maintain oxygenation while performing the apnea test?
Well, I guess if the patient is on ECMO and is already getting oxygen, or you just need to, I thought that is extracorporeal membrane oxygenation. So the thing will continue, but the main thing that you should do is to stop the assisted ventilation. And you still be passing the oxygen through the system and all that. And I don't really, a patient that is on ECMO, that one is usually for a brief period to do something. It's not perpetually, okay, septic patient and all those other patients. That's just what that's what I know about that. I need somebody to help me out of that.
Thank you, ma. I'm going to unmute Dr. Luwa Yemisi now.
Yeah.
She's raising her hand.
Okay.
Good evening. Can you hear
Good
me?
evening. Yes,
Yeah,
please.
go ahead.
All right. Still concerning the issue of the brainstem, that I just wanted to pass a comment that we should be aware that our population are becoming more aware of what is happening within the health sector. We have had in our own center where the patient's relatives actually requested, for a brainstem function to be done and the patient be discontinued from the ventilation. The request actually came from the children of the patient that we had, and they were ready to they went as far as getting a court injunction for us to carry out their orders. So I think we need to really work on what has been discussed, because our population we are becoming more aware. They are becoming more informed about what they can do, what they have access to. And so we should be in a position to be able to respond adequately. I remember in that occasion, like Dr. Oshinaiki said, we had to involve the hospital legal department, the ethics department, because the family wanted the patient off the ventilator. They had given consent. They had gone to the High Court to give us an injunction, and the hospital had to make a decision on whether we're going to do what they wanted to do or not, because they had fulfilled all the criteria. So it's not something, very soon we'll have these things on our tables and we'll have to take a decision, because once the pain relations have taken a decision and have met the legal criteria, we as the healthcare providers must have a protocol that we follow and be able to do what is expected of us. Thank you.
Thank you very much, Dr. Lua Yemisi. Dr. Akata, do you want to respond to that? Do you have any comments on that?
No, but I need somebody to comment about the ECMO patients. I don't know that one. I don't know the answer to that question. Can somebody in the audience just enlighten us?
Does any one of our seniors here have any comment on that? On oxygenation while doing ECMO? Dr. Shinaike, sir. And Dr. Ilumelu. Okay, let me unmute Dr. Ilumelu first, and then Dr. Shinaike.
Okay. Okay, I'm unmuted. Good evening, everybody. Regarding ECMO, ECMO is a method of maintaining oxygenation when you have impaired lung function. It's a bypass oxygenation mechanism or method, and it is used for a specific period of time. Actually, ECMO is not going to be part of brainstem function testing. It's not going to be. If the patient is on ECMO, then you have to conclude ECMO and get the person back on the ventilator before you now use the apneic test as part of brainstem function testing. I have never read or seen where ECMO is used during brainstem function testing. And that brainstem function testing for brain death it's not something that would last more than 30 minutes. So you really do not need to set up ECMO, which would take some longer period, some hours, just to make sure there's oxygenation whilst testing for the brainstem function. ECMO is a bit specific, like you do, cardiac bypass, using the bypass machine during cardiac surgeries for a specific purpose and for a specific period. That's my experience with that. That's my opinion and my observation about ECMO regarding oxygenation. Just as was said by the presenter, if you are going to do your apneic testing, The patient is already on a ventilator, being ventilated. Your essence is just to put off the ventilator and see if it will make respiratory efforts. And what you have to do is to put a catheter, an oxygen catheter, insufflating oxygen down the ETT while the ventilator is disconnected from the patient. And we've done this test some years ago. We had it in National Hospital. We had a prominent person who had accident and head injury. We disconnected and insufflated oxygen, and with a minute or two, the patient unconscious started making, regular respiratory efforts. So we knew there was still some, brainstem function remaining. So we had to reconnect and continue management as of then. I hope I have addressed it properly.
Thank you very much, Dr. Lumelu.
Thank
Dr.
you.
Shinaike, sir, you want to make a comment? Okay.
Yeah, thank you. Yeah, just as she has said, when a patient is on ECMO, what are you trying to do? You are trying to oxygenate the patient without the patient actually doing that himself or herself. So patient is not breathing, but you are oxygenating the patient, you are giving blood. I mean, you are maintaining the circulatory system as well. And so it's just a means of ensuring that, for example, patient with ARDS or bad heart can be managed temporarily before they go back on the ventilator. So, but apnea test, you want to see whether the patient can actually breathe or not, okay? So the important thing here is actually to take off your ventilator. So the patient must be on a ventilator to do that. Take off the ventilator and see whether the patient can actually breathe, okay, without the support of ventilator. So it's called, in fact, you can even call it a breathing test, because you want to use carbon dioxide tension, very high level, to stimulate the respiratory center. That's what you want to do. And once your patient is not breathing with that high level of carbon dioxide, then you know the brainstem is gone. So that's your basic concern, is you want to see whether the patient will respond or not. So, but you just insufflate, as she said, insufflate oxygen about 6 liters per minute into the ETT and watch. So that is basically what is done, okay? But let me just quickly say something. I think I should say this. It is possible for you not to have allowed enough time to assess the patient. If you did not allow enough time before you assess the patient, and you rush death, that patient is, those are the group of patients that you see later coming back, okay, to life. So it's always important, if you follow all the steps, unlikely that you have that patient reflexes and some other movement, but it is unlikely that that patient will fully recover again. So the lesson is that let us from just you get a patient and just do apnea test, or just follow the sequence as she has given us today, and I'm sure we'll be able to make a good diagnosis. Thank you very much.
Thank you very much, sir. I want to say a big thank you to our presenters, Dr. Chigozie Wandu and Dr. Blessing Akata, and to our audience for this evening spent learning and deliberating and refreshing knowledge. And I also want to say that we should move onwards from this. Thank you, Dr. Shinaike, that you say we're going to take this up. So there should be guidelines for Nigeria, because we actually have a bit of issues at times with patients in ICU who are brainstem dead and are on ventilators. And then you cannot turn off those ventilators. And there are patients who are waiting bed space. And then you have to go through a lot of processes trying to, try to make bed space available and all that. So I'm very happy that we've agreed at this meeting that this is going to be taken up. Nigeria is going to have its own guidelines, and that for those who were a bit confused on how to go about it, I thank Dr. Shinaike and all others who have given suggestions on processes that can be done in the meantime, how to handle those situations. So I'll hand over now to Dr. Briggs. Are you here, ma? Dr. Briggs?
Thank you very much.
To make
yes,
some
I'm
final
here.
comments.
Yes, thank you very much, Dr. Sazua, for the good moderation. Thank you once again to the speakers and the entire House. We have been thinned out now to about half our startup number. I would like to hand over to the President. Madam President, over to you, please. It's Professor Boli. Professor Boli Waso. Hello, Madam President. Okay, she's raising up her hand. Please take over, ma.
Okay. Hello, thank you very much for the session today. Sorry about the hitches we have had here and there. There's, I think it's a growing process, so we learn as we go. I am supposed to say that there will be another meeting next week, and Dr. Venatius Aniobi is to give us a lecture on ambulatory anesthesia, if I'm correct. I think that will be the only session for the day. I'm not sure.
Yes, it will be.
Okay, so thank you very much, Dr. Briggs. We thank our speakers, our moderator. We thank all the participants. We appreciate you. Have a good evening. Have a good rest of the evening and good weekend. We'll see you more next week. Thank you very much. Back to you, Dr. Briggs. Is there any other thing?
No, please, Madam President.
Oh, thank you so much. Thank you, everybody. I appreciate you. Good night.
Good night, everyone. God bless. Bye.
Bye. Bye for now.